நலத்தை உயர்த்திவே இன்றே முடிவு செய் உடல் நலத்தை நீயும் உயர்த்திவே.
Because our bodies and the future we hold, we want for you to see that everybody can win. Could it be education or contraception? Girls and boys will always be fine.
We are family and we are planning to go around the world, telling everyone that we demand a voice. We are family and we are planning to go around the world, telling everyone that we demand a choice. We are family and we are planning to go around the world, telling everyone that we demand a voice. We are family and we are planning to go around the world, telling everyone that we demand a choice. We are family and we are planning to go around the world, telling everyone that we demand a voice. We are family and we are planning to go around the world, telling everyone that we demand a choice. We are the stars, the bright and morning stars, with the power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.
Because our bodies and the future we hold it. We want for you to see that everybody can win. Could it be education or contraception? Everyone will always be here to sing.
We are family and we family and we are planning to go around the world, telling everyone that we demand a choice. We on the ground in every area. We're the ones to make a world a better place. We want the best, we want the way. There's something for a future so bright.
Because our bodies and the future we hold it. We want for you to see that everybody can win. Could it be education or contraception?
rise up, won't keep our eyes shut, we ain't got enough. I know you tired of seeing things the same way, but in time you realize that things change. We the demographic dividend, you see the work that we putting in. I'ma stay true to me and use my opportunity to show you how to build a community with unity.
Good morning, good afternoon, and good evening. My name is Caroline Moreau, and I'm really delighted to introduce this virtual ICFP session on innovations in research in response to the COVID-19 pandemic. We gather today at a difficult time as the second wave of COVID-19 is raging in many parts of the world, bringing its toll of fear and mourning to many families. And so in this context, our work as public health researchers, practitioners, and advocates has found more immediate relevancy as we seek to understand and respond to the health and social implications of the pandemic on a global scale. The epidemiology, response, and impact of the pandemic has varied widely across the world. Each presentation today showcases an innovative research response utilized to understand the diverse impacts of the COVID-19 pandemic on family planning and reproductive health. I will now take a few minutes to welcome our Francophone audience before I introduce our 4 esteemed colleagues who will be discussing their work. Bonjour à tous et bienvenue à cette session virtuelle de l'ISFP sur les innovations en recherche et réponse à l'épidémie de COVID-19. Nous nous réunissons aujourd'hui en des temps difficiles où la deuxième vague de la pandémie fait rage dans de nombreuses régions du monde. Et dans ce contexte, notre travail en tant que professionnels de santé publique, chercheurs, praticiens ou promoteurs de la santé prend un sens plus immédiat et nous conduit aujourd'hui à chercher à comprendre et à répondre aux enjeux de santé et aux enjeux sociaux qui sont liés à l'épidémie. L'épidémiologie, les réponses et l'impact de la pandémie varient largement à travers le monde. Et dans ce panel, nous mettrons en perspective les expériences venant d'Afrique centrale, d'Afrique de l'Est, d'Asie et d'Afrique du Nord. Chaque expert présentera une recherche innovante qui permettra de comprendre les différents impacts de l'épidémie sur les pratiques en matière de planning familial et sur la santé reproductive. Let me now welcome and introduce our 4 presenters. And I'll start with Dr. Kangwana. So let me turn first and introduce Dr. Kangwana, who will be discussing the effects of COVID-19 on sexual and reproductive health and rights of adolescents in Kenya. So Dr. Kangwana is an epidemiologist with several years working in public health research, both in developing and developing country settings. And she currently works as a senior program officer at the Pop Council in Kenya and is the principal investigator for a study testing how to improve access to community mental health services in urban informal settlements in Kenya. She's also co-investigator on a number of studies evaluating ways to improve adolescent health and well-being in developing countries. Before she joined the council, Dr. Kangwana worked as a research associate at the Imperial College of London and at the Center for Infection Prevention and Management, and at the Kenya Medical Research Institute Wellcome Trust Research Program. She holds a PhD in public health from the Open University in collaboration with the Kenya Medical Research Institute Wellcome Trust Research Program, as well as a master's in global health sciences from the University of Oxford. She has a master's degree in pharmacy and is a registered member of the Pharmaceutical Society of Great Britain. Notre deuxième présentateur, le docteur Lambert Chalachala, présentera sur les innovations mises en place par les organisations en RDC pour pallier aux difficultés d'accès à la planification familiale. Le docteur Jean Lambert est docteur en médecine à l'université de Kisangani en RDC. Il est aussi spécialiste en santé publique, après avoir obtenu son master en santé maternelle et infantile à l'université de Caroline du Nord aux États-Unis. Il cumule près de 2 décennies d'expérience de terrain dans la gestion et l'évaluation de nombreux projets en santé qui sont liés au VIH, à la nutrition, à la malaria, aux violences sexuelles, ainsi qu'à l'évaluation et à la gestion des situations d'urgence, dont l'épidémie d'Ebola. Il a également conduit et participé à plusieurs études et recherches opérationnelles, à la fois en RDC et en Côte d'Ivoire. Après avoir travaillé pour le gouvernement, le docteur Jean Lambert a travaillé successivement pour Médecins sans frontières, Médecins du monde et l'École de santé publique de Kinshasa. Depuis 5 ans, il est collaborateur de recherche à l'Université de Caroline du Nord au sein de la Carolina Population Center. Il est aujourd'hui basé à Kinshasa et il représente en RDC le Family Planning Country Action Process Evaluation, qui est un projet d'évaluation qui examine les portefeuilles d'investissement en planning familial de la fondation Bill et Melinda Gates à la fois au Nigeria et en RDC. En tant que Rotary Peace Fellow, le Dr Jean Lambert est un ambassadeur de la paix et il est impliqué dans de nombreuses initiatives de résolution de conflits et de promotion de la paix entre communautés en RDC. Let me turn to our third presenter, Dr. Laura Lindberg, who will be presenting on understanding the impact of COVID-19 on sexual reproductive health in the United States. She's a principal research scientist at the Guttmacher Institute, and as a social demographer, Dr. Lindberg focuses on measuring trends, determinants, and consequences of sexual and reproductive health in the US, particularly regarding the needs and behaviors of adolescents, and working to improve the quality of survey data and SRH behaviors. Over the course of her career, she has conducted policy-related research on adolescent sexual behaviors, sex education, adolescent preventive services, unintended pregnancy, and contraceptive use. She's currently principal investigator of an NIH funding research related to improving the measurement of abortion and US surveys. She leads and contributes to the designing, fielding, and analysis of multiple surveys, including a national survey to assess the impact of COVID-19 pandemic on women's fertility preferences and access to SRH services. Dr. Lindberg has published in many top peer-reviewed journals in the field, including Demography, Studies in Family Planning, American Journal of Public Health, as well as Perspectives on Sexual and Reproductive Health. And additionally, she plays a major role at Guttmacher in providing expertise on SRH health topics to the media. She received her undergrad degree from Princeton University and earned her MA and PhD in sociology at the University of Michigan. Finally, but not least, Dr. Vinit Sharma will be presenting on modeling possible scenarios of the pandemic's effect on family planning and fertility in the region and responses from the national programs. Dr. Sharma is a passionate advocate for the health of women, young people, and disadvantaged population. He's an award-winning expert and is a respected thought leader with nearly 3 decades of technical experience of working in multicultural environments and leading teams in the UN agencies, academic, and research institution. His main competencies include leadership, policy, advocacy, rights-based programming, strategic communication, forging strategic partnerships, and resource management. His technical expertise spans from adolescent health, maternal, newborn, and child health, family planning, human nutrition, health management, including health system strengthening as a disease surveillance and eradication. He has a postgraduate training in adolescent health and sexuality from the University of Lausanne. He has lived, traveled, or worked in more than 50 countries around the world in complex and insecure environments as well. And last but not least, he's recognized as a good team player. So let me turn the mic and welcome everybody and turn the mic to Dr. Kangwana. Thank you very much.
Hello, everyone. I shall be presenting on the effects of COVID-19 on sexual and reproductive health and rights of adolescents in Kenya. My name is Beth Kangwana, and I'm presenting on behalf of a team from the Population Council's Poverty, Gender and Youth program. The study was a collaboration between the Executive Office of the President and Population Council. Next slide, please. The overall objectives for this presentation are to present findings from phone interviews on the effects of COVID-19 on sexual and reproductive health and rights in Kenyan adolescents. We then use qualitative findings to understand the effects observed from the quantitative findings. We shall be using these data to inform COVID-19 adolescent programming and policy in Kenya. Next slide, please. From the quantitative data collection, we collected data from cohorts that were already established from previous studies. Data was collected from around 4,000 adolescent boys and girls across 4 counties. Adolescents were between the ages of 10 to 19 years old. So the areas or the counties that we looked at was Wajir County, which was in the northeastern part of Kenya. We managed to interview just over 1,000 adolescents, boys and girls, in July last year. We also went to Kilifi County, which is at the coast of Kenya. We interviewed around 600 adolescents in August. In Nairobi County, we interviewed just over 1,000 adolescents in June last year. And Kisumu County, which is in the Lake region, we were able to interview just over 1,000 adolescents in August. Next slide, please. The topics covered for the quantitative data collection were on COVID-19 knowledge, attitudes, and practices. We also looked at the effects of COVID on, as I said, sexual and reproductive health, but this was only in adolescents 15 years and above. We looked at the impact of COVID on violence, on other aspects of health, education, and social interactions. These were structured phone interviews that took around 45 minutes each and were carried out in the local dialect. Preliminary analyses was carried out and consisted of percentages calculated per study site. Selection bias was likely to be a limiting factor since we were only able to interview those who had access to a phone. Next slide, please. We were able to carry out 174 qualitative interviews on adolescent girls, including those who were pregnant or already had children, boys, their parents, and key informants. We carried out these interviews in November of last year, and the purpose of the interviews was to provide some context to the quantitative findings. The interviews were carried out in person, however, we implemented COVID-19 mitigation measures. The in-depth interviews were recorded with participant permission and transcribed directly into English. Transcripts were then validated and reviewed for quality assurance, and coding took place on Atlas TI, where themes and sub-themes were identified. A pre-selected number of participants were double-coded to ensure internal validity. Next slide, please. In the results, we will cover the effects of COVID-19 on access to healthcare services and general health, on violence, pregnancy, early marriage, and family planning, and female genital mutilation. So we'll start off with access to healthcare services and general health. From the quantitative data, we saw that around 10% of adolescents were likely to skip healthcare in all sites apart from Wajir. Girls were more likely to skip healthcare compared to boys. The main reason for skipping care was cost, followed by either lack of services, medicines, or fear of COVID-19 infection. The data also showed that adolescents were 2.5 times more likely to skip necessary health services if their adult head of the household had lost their full income. Next slide, please. Among menstruating girls, over half of menstruating girls had trouble getting menstrual hygiene management products since the COVID-19 pandemic started. This was in all the counties apart from in Wajir, where around 1/3 of girls reported poor access to MHM products. And the reason for this lack of access was due to lack of financial resources to purchase the products. Next slide, please. There was also a food security crisis. With the exception of Wajir County, around 70% of household heads and close to 80% of adolescents reported skipping meals or eating less in the past 2 weeks due to COVID-19. This was higher in urban compared to rural areas. Next slide, please. From the qualitative findings on general health, interestingly, adolescents reported that adhering to COVID-19 prevention measures had contributed to a measure to increased general health for adolescents. And one quote from an adolescent who said that my health has improved because right now you will find that many people are maintaining social distance, and that prevents you from contracting other diseases like TB. You find people have face masks, people are sanitizing, so it has prevented us from other diseases like cholera, diarrhea, cough, TB, and many others. However, some adolescents reported that a lack of money for a proper diet compromised their health and nutrition. And one adolescent said that my health was affected by lack of enough food since we were only eating twice a day. We, includes the siblings, are now weak. Next slide, please. Similar to the quantitative findings, lack of money to pay for services limited their ability to access healthcare services. Due to financial challenges, purchasing of food took priority over healthcare. Another quote from a stakeholder says that because there is no money and the amount of money they get in the family, it is used to buy food. When it comes for money to go to the hospital, it is not available. Such a person is affected and has to wait for money to be available. Other barriers mentioned to accessing healthcare included lack of medication, lack of health personnel who were, some of them were on strike during that period, during the COVID pandemic, and also movement and time restrictions due to the curfew. Next slide, please. Some adolescents reported that the fear of getting a COVID test and it being positive held them back from seeking treatment from a health facility. Another quote from an adolescent said that there is a day I had chest pains. I was coughing and I also had a cough. And I could see that in the television, those are the symptoms of coronavirus. So I was afraid to go to the hospital because maybe if I could have gone to the hospital, they could have diagnosed me with corona and maybe it was not corona. And it will involve a lot of expenses to get the treatment. There was also a fear of contracting the disease if they visited the health facility. Next slide, please. We'll now go on to look at the impact of COVID-19 on violence. Next slide, please. From the quantitative data, adolescents reported experiencing increased tension of violence. This included emotional, physical, or sexual violence at home. This was highest in Nairobi and Kisumu counties, where around 1/4 reported increased tension. Far fewer adolescents reported increased violence. Next slide, please. Emotional violence was experienced more than physical and sexual violence. For all reports of violence, 1/2 to 3/4 said it was happening more than pre-COVID times. Majority of those who were reporting sexual abuse were girls. Next slide, please. From the qualitative survey, reasons given for the rise in violence was as a result of an increase in crime, conflict, domestic violence in the community during the COVID period due to loss of jobs and idle youth. Some adolescents developing aggressive behavior as a result of domestic violence and conflict experienced at home during the COVID-19 period. And one quote from the parent, just to highlight this, said that during this time, during the COVID-19 pandemic, there is a lot of conflict because there is no money. Then the children see the conflict. The children are also bitter. They bring it out. So they see you having something, they can come and steal. You joke around with them, they will beat you up because they are already angry. Life is so unfair on them. From the quantitative data, we saw very low rates of pregnancy or child marriage so far. So around 1% of girls in the sample were either pregnant or married since COVID-19 had started. When it came to family planning, in Nairobi, Kilifi, and Kisumu County, over 90% of adolescent girls reported not wanting to be pregnant and not being sexually active. We also saw low use of contraceptives, so less than 1/3 of all adolescents were using contraceptives. And we did not ask about family planning use in adolescents residing in Wajir, since this was a culturally sensitive topic. However, we have seen that the risk factors for early pregnancy and marriage have been exacerbated due to the pandemic, and we've seen these risk factors have increased, such as economic stress and low use of contraceptives. Next slide, please. The qualitative findings further highlight the impact of COVID-19 on exacerbating adolescent pregnancy risk factors. Many adolescents mentioned increased sex for money or PADS, especially with within the COVID-19 pandemic, where we see poorer access to mental health hygiene, menstrual hygiene management products. Respondents also mentioned idleness and increased boy-girl relationships have also resulted in pregnancies, and lack of free family planning provisions in the health facilities during the COVID-19 period. And another quote from an adolescent in Nairobi who said that during the Corona period, I went for the first time and they told me that the family planning method I want is not available. I went to the second time and they gave me an option, not the one that I wanted, that they don't have the one that I want and I should instead take a different one. The quantitative findings highlight the impact of COVID-19 on exacerbating adolescents' early marriage risk factors, such as violence at home, pregnancy, financial challenges, which push girls to early marriage. Some girls plan to enter early marriage as a strategy of creating an avenue for financial support. And we see this from a comment from an adolescent girl in Wajir who said, there are these girls who married out of their own volition because they heard that since the schools were closed for a very long time, about 6 or 7 months, the students will have to repeat a class to catch up on what they had lost. And therefore to them, that is a waste of time. Hence, the alternative is to get married. Next slide, please. Finally, looking at female genital mutilation. Mainly this was practiced in Wajir County in the northeastern part of Kenya. And from the qualitative findings, we learned that adolescents attest to FGM secret practices, while parents and stakeholders deny its existence. And we also see that COVID-19 has had no major influence on this practice. This was what we learned from the qualitative findings. So thank you. That's the end of my presentation, and I'm happy to address any questions or comments.
Alors, je commence. Mon nom est Lambert Chalachala. Donc, je travaille pour l'Université de la Caroline du Nord et je vais donc vous présenter le résumé du travail d'évaluation rapide des effets de la pandémie de COVID-19 sur le portefeuille d'investissement en planification familiale de la Fondation Bill et Melinda Gates en République démocratique du Congo. C'est un travail d'équipe que nous avons fait avec l'ensemble de l'équipe de FPCAP que je représente aujourd'hui. Prochain. Next. Yes. Voilà le plan de notre présentation. Je vais commencer par faire un aperçu du projet FPCAP et du portefeuille en planification familiale de la Fondation Gates en RDC. Ensuite, je vais présenter très rapidement la méthodologie que nous avons utilisée pour réaliser cette évaluation rapide et aussi une situation de la COVID-19 en RDC par rapport aux statistiques. Je vais présenter un échantillon de résultats qualitatifs et quantitatifs que nous avions collectés et ensuite nous allons chuter par une conclusion. Next. Voilà, next. Next, please. Voilà. Donc, objectif de FPCAP, ce projet, c'est un projet de l'Université de la Caroline du Nord, comme je l'ai dit, et qui a pour objectif d'examiner les systèmes complexes des portefeuilles d'investissement de la Fondation en RDC et au Nigeria. Et c'est là dans le but d'atteindre les objectifs que chaque pays s'est fixé en matière de taux de prévalence contraceptive moderne. Et à partir d'une théorie des changements que nous mettons en place, FPCAPE génère donc des évidences pour savoir comment et pourquoi chaque mécanisme qui est mis en place peut réaliser un changement durable. Et cette analyse se passe au niveau du portefeuille. Nous nous concentrons au niveau global de tous les projets et non pas des projets individuels pour savoir les interactions et les synergies qui sont mises en place aux différents, entre tous les différents programmes pour avoir un objectif commun. Et ce travail se fait de manière prospective pour permettre aux différents projets d'avoir accès à nos résultats et de pouvoir adapter leurs activités en fonction des résultats que nous réalisons. Prochain. Next. Voilà. En République démocratique du Congo, le portefeuille d'investissement regroupe une dizaine de projets qui sont donc représentés ici en fonction de chaque domaine d'intervention. Next. Yes. Et là, nous allons vous présenter rapidement et brièvement la méthodologie que nous avions utilisée pour cette évaluation. Next. Voilà. En République démocratique du Congo, le tout premier cas de COVID-19 a été détecté le 10 mars 2020 et une semaine après, le gouvernement a été assez réactif pour mettre en place des mesures barrières, des mesures de fermeture des frontières, fermeture des écoles, des universités pour limiter la propagation de la pandémie qui avait commencé uniquement à Kinshasa. Et à partir 2 mois après, à partir du mois de juin, avec le contrôle de l'épidémie, il y a eu un début d'assouplissement des mesures de restriction, puis ces mesures ont été complètement levées à partir du mois d'août. Mais avec la deuxième vague qui a repris avec plusieurs cas positifs depuis décembre, le gouvernement a repris de nouvelles mesures de restriction ou de couvre-feu et de fermeture des écoles depuis le 15 décembre. Alors, à ce jour, jusqu'au 10 janvier, le nombre de cas positifs dépités en RDC avoisine les 20 000 et il faut noter que 22 provinces sur 26 sont pratiquement touchées, mais l'essentiel des cas sont concentrés au niveau de la ville de Kinshasa. Next. Voilà. Pour réaliser notre évaluation rapide, nous avons donc cherché à étudier l'impact de la COVID-19 sur le portefeuille spécifique des investissements. Et c'est là, nous avons exploré quelques indicateurs qui concernent la mise en œuvre des activités de planification familiale, l'utilisation et la distribution, ainsi que les indicateurs de rupture des stocks des méthodes de planification familiale. Next. Voilà. Nous avons donc utilisé cette approche des méthodes mixtes pour collecter des données directement à partir des bénéficiaires. Donc, nous avons mis en place un questionnaire que nous avons soumis aux différents bénéficiaires du portefeuille. Ils ont fourni des informations qualitatives et ces informations qualitatives, quelques-uns parmi eux, nous ont aussi fourni des données de services et nous avons combiné toutes ces données pour sortir des résultats qui sont plus riches et plus complètes pour permettre d'évaluer les effets possibles de la COVID-19 sur les activités qu'ils sont en train de mener. Next. Donc, il faut dire que nous avons réalisé des séries de collectes de données auprès de de nos partenaires et à chaque fois, nous avions produit des rapports succincts, des brefs rapports que nous avions partagés avec les équipes du gouvernement à travers le programme national de santé de la reproduction, mais aussi nous avons partagé avec les bénéficiaires faisant partie du portefeuille PF des Gates, mais aussi nous avons partagé avec les officiers des programmes de la Fondation. Et les feedbacks que nous avons reçus est que les bénéficiaires ont été ravis de lire ces brefs rapports parce que cela leur permettait d'être informés sur l'impact de la pandémie sur les autres bénéficiaires et de savoir qu'est-ce que les autres bénéficiaires avaient mis en place pour répondre à la situation de la COVID-19, mais aussi les officiers de programme ont utilisé ces rapports pour des fins de planification. Voilà, nous allons dire ici un petit mot sur les résultats qualitatifs. Next. Voilà, nous avons eu un groupe d'activités qui ont été obligés d'être arrêtés à cause de la COVID-19. Donc, toutes les activités qui nécessitaient des rencontres en présentiel, des réunions, des rencontres physiques ont été interrompues pendant les temps forts de la pandémie. Mais, comme je l'ai dit avant, la plupart de ces activités ont commencé à reprendre à partir du mois d'août, mais tout en maintenant les précautions, les mesures barrières contre la COVID-19. Next. Voilà. Il y a eu quand même aussi un groupe d'activités qui ne se sont pas arrêtées et qui ont continué à avoir lieu. En général, toutes ces activités du programme qui se sont poursuivies, mais avec certains ajustements, c'est-à-dire que les activités qui pouvaient être faites par voie virtuelle se sont continuées, telles que la diffusion des messages. Il y a eu aussi la collecte et l'analyse des données des routines de planification familiale. Il n'y avait plus moyen d'envoyer les équipes descendre sur le terrain dans les formations sanitaires pour collecter les données, mais ça se faisait, ça a commencé à se faire via des plateformes virtuelles. Les données étaient envoyées soit par WhatsApp, soit par email, et donc ces activités-là ont pu continuer comme auparavant. Next. Voilà. Et donc, les bénéficiaires faisant partie du portefeuille Gates se sont adaptés pour essayer de fournir les services tant soit peu malgré les restrictions, malgré les difficultés liées à la COVID-19. Donc, presque tous ont donc réussi à ajuster la mise en œuvre de leurs activités afin de maintenir les objectifs des projets, de maintenir les résultats de chaque programme. Bon, il faut noter qu'au-delà de l'enquête que FPCAPE a mis en place, il y a aussi deux autres projets, notamment PMA et Global Early Adolescents Survey, qui ont aussi mis en place des évaluations pour essayer de comprendre l'impact de la COVID-19 sur la mise en œuvre des activités PF, mais aussi sur les jeunes et les adolescents. Prochain. Voilà. Nous allons aussi aborder quelques résultats quantitatifs pour essayer de voir les effets de la COVID-19 sur leurs résultats. Next. Voilà. Parmi les partenaires avec qui nous avons travaillé au sein du portefeuille d'investissement, quelques-uns nous ont fourni leurs données de routine, et lorsque nous analysons ces données, ça ce sont les données fournies par DKT, et ces données, il faut noter que la plupart de ces données concernent la ville de Kinshasa, mais pour DKT, ça concerne 18 provinces sur les 26. Alors, il faut dire que les formations sanitaires qui sont soutenues par DKT ont connu une certaine diminution du nombre d'utilisatrices par méthode de planification familiale à partir déjà du mois de février, mais vous voyez la ligne jaune qui est coupée là, c'est au début du confinement au mois de mars. Donc, tous les indicateurs ont eu tendance à baisser jusqu'à la fin du confinement au mois de juin, juillet et août, lorsque les activités ont repris et les indicateurs aussi ont commencé à aller en hausse. Next. Voilà. La même chose aussi pour les données de Engender Health et les données du projet Aqual 3 de Tulane University. Et donc, tous ces indicateurs ont montré qu'il y a eu une baisse drastique à partir du mois de mars jusqu'au mois de juillet, août pour les données de distribution et d'utilisation des méthodes de planification familiale à Kinshasa. Mais vous constaterez évidemment, comme tous les autres graphiques, que cette baisse a bien commencé à partir du mois de février jusqu'au mois de juillet, août. Next. Voilà, la même chose encore ici par rapport même à la distribution communautaire. Les agents de santé communautaire qui, en général, offrent les méthodes de planification en porte-à-porte au sein de la communauté. Évidemment, comme il y a eu confinement, comme il y a eu réduction des mouvements, nous constatons qu'à partir du mois de mars, il y a eu chute des indicateurs et tout cela a repris à partir de juillet lorsque on a levé le confinement. Voilà. Un autre indicateur intéressant était de savoir un peu comment ont évolué les ruptures de stock, ce qui est normal. En jaune, vous voyez, c'est le mois de mars pour pratiquement toutes les méthodes offertes. À partir du mois de mars, il y a eu hausse des ruptures de stock dans les différentes formations sanitaires parce qu'évidemment, il n'y avait plus moyen d'organiser la logistique pour l'approvisionnement de ces méthodes. Et donc, les structures de santé, les formations de santé et les hôpitaux ont manqué des intrants par rapport à toutes ces méthodes de planification familiale ici à Kinshasa. Prochain. Voilà. Next. En conclusion. Prochain. Next, please. Voilà. Et donc, qu'est-ce que nous pouvons dire en conclusion par rapport à la situation de la COVID-19? Dans l'ensemble, tous les bénéficiaires faisant partie du portefeuille d'investissement se sont adaptés rapidement et efficacement lorsque la COVID-19 est apparue en RDC. Tout le monde donc a réagi vite pour intégrer les précautions et les messages de prévention de COVID-19 dans toutes leurs activités. La plupart des perturbations qui ont survenu, se sont survenues entre le mois de mars et le mois de mai pendant la période difficile de confinement, mais toutes les autres activités qui ont réussi à s'adapter ont pu continuer à être menées. Il faut dire quand même avant de finir que le travail que nous avons fait avait donc pour objectif d'avoir les effets rapides par rapport à la COVID-19 sur les interventions de planification familiale. Nous n'avons donc pas réalisé des analyses très approfondies et nous n'avons pas non plus comparé avec les courbes des années antérieures pour voir si à long terme, la COVID-19 a eu un impact très important ou non sur la routine des activités. Mais c'était un outil que nous avions voulu mettre rapidement à disposition des partenaires pour leur permettre de savoir déjà ce que les autres aussi avaient fait pour s'adapter par rapport à la situation qui était totalement inédite pour tout le monde. Personne n'était préparé à ça avant et cela nous a donc permis d'avoir une certaine image de la situation de la COVID-19 et des effets de la COVID-19 sur les activités de planification familiale du portefeuille d'investissement de Gates en RDC. J'ai dit et je vous remercie. Si vous avez des questions ou des préoccupations, je serai bien ravi de pouvoir y répondre. Merci beaucoup.
So thank you for the opportunity to speak with you today. I'm pleased to talk about the challenges that have been going on in the US around COVID and SRH, and some hope for opportunities for really improving the situation. Next slide. As I'm sure you're all aware, the US has been particularly hard hit with nearly 400,000 COVID-related deaths thus far, and a marked disruption in our social and economic lives. Next slide. It's against this backdrop that today I want to talk about 4 things. First, I will present findings from a survey we conducted in May, early in the pandemic, asking women about their sexual and reproductive health experiences. We use that information to consider what we think will be an upcoming baby bust in the US, and then highlight efforts that providers have taken to reduce sexual and reproductive healthcare barriers. Finally, I will share some priorities for new policy initiatives to improve SRH. Next slide. So let's talk for a second about the SRH context before COVID in the US. Here we have considerable variation across states in the laws governing SRH care and therefore really its availability. Although telehealth certainly existed, there was minimal evidence of its use for contraceptive care or of its effectiveness for this type of service. The US has a contentious environment around abortion, and in many states, there were extensive barriers to accessing abortion even pre-COVID. And the impact of all of this is severe racial and economic disparities in women's sexual and reproductive health and well-being, and their ability to have children if and when they want. Slide 5. So in early May, we interviewed a national sample of women in a rapid response online survey. This early data allowed us a first look at the impact of COVID on women's lives, and we will be returning to the field this spring. The full report is available on the Guttmacher website. Our data show that the COVID-19 pandemic is a public health crisis, but it also dramatically impacts people's most personal and intimate lives. When people are uncertain about the future, they just may not feel like it's the right time to make long-term decisions about having a child. So here in this chart, we show that pregnancy desires plummeted early in the pandemic, as 1 in 3 women reporting wanting to delay or reduce their childbearing specifically because of COVID. And the ripple effects of COVID-19 exacerbated existing inequalities in the US. For example, we found that Black and Hispanic women were more likely than white women to report shifting fertility preferences because of the pandemic. Together, these changes in preferences suggest that we should expect fertility rates to decline. Next slide. So US fertility was already going down before COVID. So think about those fertility rates on a downward hill of a ski slope. And COVID-19 is an avalanche suddenly roaring down that mountain. That downward slope is even likely to get bigger. Now, it takes 9 months to have a baby, of course. So we're just starting to see the first months of COVID-influenced births, but some state data is already showing evidence of declines in fertility. The question is, how big will these declines be and how long will they last? And will there be some subgroups, particularly those who've been able to work from home and are gaining income during this period, for whom fertility might rise? Next slide. The pandemic is also making it harder for people to access the contraception they need to make critical life choices around fertility. In our national survey, 1/3 of women reported problems with access to contraception or other sexual or reproductive health care because of the pandemic. But providers have made many changes to how they are providing SRH services, and I really want to applaud and call out the innovations and resilience of women's healthcare providers. Next slide. So let's first talk about service delivery for contraception. Some of the things that happened during the COVID period include expanded use of telehealth for women who couldn't physically go to their provider, as well as providers starting to provide curbside pickup of supplies or even mail delivery. There was also growth in the use of online suppliers and pharmacies. Some providers shifted to mailing patients self-injectables for depots so they could do this at home themselves, and to promote extended use of LARCs and long-term supply provision like 3-month pill packs. The question for the future is, to what extent will all of these innovations be continued once we go back to, quote, a more normal healthcare and social environment? Next slide. Now let's look at the changes to service delivery around abortion. Early in the pandemic, some states used the pandemic as an opportunity to limit abortion access, and they put into place new restrictions that identified abortion as non-essential healthcare that shouldn't be taking place or could be delayed. These early restrictions generally were either overturned in court or they ran out, and this isn't the environment we're currently in right now. But I think that advocates in the SRH community really saw the need to speak up loudly that abortion is indeed essential healthcare and essential to women's lives and something that cannot be delayed. US providers have shifted to an increased reliance on medication abortion, again, even doing curbside pickup for this service. They've done their best to reduce testing, developing protocols for no-touch and low-touch abortion as allowed in their state. We don't yet know what the impact of this will all be on abortion incidents, and we'll be needing to track this. Next slide. Finally, let's look at changes to service delivery around preventive SRH care, including STIs. Because many people couldn't or were too fearful to see their healthcare provider face-to-face, there has been preventive care, whether that's pap smears, mammograms, and in particular for adolescents, HPV vaccinations. It has also meant missed STI screenings and less access to symptomatic testing. In fact, in the US, we've had supply shortages for things like swabs needed for STI tests because of supplies being diverted to COVID testing. Some providers are mailing STI tests to patients for patients to do themselves, as well as doing more presumptive treatment. So the question looking forward is, again, when things get back to normal, will people catch up on this mispreventive care? And what implications will this miscare have for longer term health? Slide 12. As I've mentioned, one way women are getting care has been through increased use of telemedicine. In our national survey, for example, we found that 24% of pill users reported that they had switched to using a telemedicine appointment. Next slide. While the opportunities for telemedicine are great, I think there's a lot of challenges for telehealth for SRH that we're going to need to engage with. This includes trust in the technology, as well as a potential lack of privacy. Think particularly about an adolescent who's home with her parents, or a woman who doesn't want her partner to hear her talking with her provider. Language may be a barrier to using online services, as well as the reality that not everyone has access to either broadband services or a computer for the video telehealth sessions which many insurers have required. And this gets to the legality question. Expansion of telehealth was possible during COVID because states and the federal government changed many coverage and reimbursement laws. Finally, there's a challenge for services that do need to happen in person, like a pap smear. So how do we prioritize who needs to see a healthcare provider in person and for what service? Next slide. As we expand telehealth in the future, there are 3 attributes that I think we really need to be focusing on. Access is one of them, whether through improved technology, improving digital literacy, or expanding insurance coverage. We also should care about quality. How do we make sure that the quality of the telehealth visit is not a lesser good than what an in-person healthcare visit would have been? And cross-cutting both of these attributes is the issue of equity. That is, how do we make sure that people have equitable access to quality care? At scale, telehealth may be cheaper than in-person to provide, and we don't want telehealth to become the poor woman's lesser standard of care. Next slide. As you all know, the United States soon has a new president who is supportive of sexual and reproductive health and rights. So this means that there are many opportunities for new policies. Here I point out just a few. I bring up again the need to support telehealth and to maintain and expand some of the recent policy changes that facilitate it. We also need to work to ensure abortion access, including making medication abortion accessible without an in-person visit. There are opportunities here to really rethink and rebuild our healthcare systems to make them function better. Striking down both the global and the domestic gag rule will help to improve SRH in the United States and abroad. And here in the US, a lack of health insurance remains an issue. And with rising unemployment, there are concerns of women losing their healthcare coverage. So we need greater efforts to build a universal healthcare system that assures care for all. Finally, I think all of this together can help to support and move us towards reducing disparities in access to SRH care and improve outcomes. Next slide. Thanks for your time and listening to this. I've included links here for more information about Guttmacher's work on social media and our website and my own Twitter as well. Thank you.
Hello, everyone. My presentation today focuses on the impact of COVID-19 pandemic on the sexual and reproductive health issues in the Asia-Pacific region. I will also share some interesting program innovations that have been piloted successfully in many countries of the region to overcome the challenges posed by the pandemic. Next slide, please. The ongoing COVID-19 pandemic is posing unprecedented challenges to governments. Health systems are now focused on life-saving measures and critical care, and key health staff have been diverted to focus on COVID-19 response. Community distribution, house-to-house counseling, and satellite sessions have been hampered or just have been discontinued. Many countries have witnessed large-scale movement of populations, with millions of workers having lost their jobs and being compelled to travel back to their homes thousands of miles away, resulting in a confounding socio-economic crisis. Next slide, please. Even within the healthcare facilities, the immediate focus appears to be on life-saving interventions. And family planning services, sexual reproductive health services are being sidelined. This was also documented during the Ebola epidemic in West Africa. Health supply chains are performing at suboptimal levels, with high probability of stockouts of essential sexual and reproductive health commodities. There has been a general decline, global general decline in manufacturing, which has been further complicated by import and export bans and global supply chain disruptions. At the family and individual level, as my colleagues pointed out, lockdowns have resulted in cloistering of couples together and increased the possibility of sexual activity and the resulting unintended pregnancies. Unintended pregnancies because contraceptive availability at home is likely to run out after some time, and procuring additional stocks is difficult. Many couples are now switching to less effective traditional methods, thereby increasing the chances of unintended pregnancies. Next slide. In Bangladesh, the Population Council study among more than 950 adolescent girls from 3 of the project districts found that 54% of the girls had cuts on health care and medicines in their families. Only 13% of them reported any access to services, including SRH services. In Cambodia, a decline by 20% to 24% has been observed in women seeking sexual and reproductive health services, while in Nepal, we observed 10% decline in short-acting contraceptive methods. The health system anticipates more than 19,000 additional intended pregnancies during 2020. Next slide, please. In Pakistan, a study among more than 200 women from the lowest socioeconomic strata found that the lockdown has forced women to switch from modern to traditional methods due to the non-availability of methods and financial constraints. And also, as we found out earlier, the pandemic has resulted in food insecurity. One of the women pointed out, Corona will not kill us, but hunger surely will. Something to really ponder upon. In Indonesia, More than 900 private practicing midwives have closed their services, their practices due to lack of protection, PPEs, personal protection equipments, and many of them have died because of infection. The National Family Planning Board, BKKBN in Indonesia, estimates 370 to 500,000 additional unintended pregnancies during 2020. Next slide, please. This is a slide from our partner organization, IPPF, which had analyzed data from March to May in 2020. And as you can see, all throughout their clinics in many countries and many districts, there has been a reduction from 40 to 80% across the board in all services related to sexual and reproductive health and their utilization. Next slide, please. The impact on family planning, as we pointed out just now, has been at various levels. At the central warehouse level, there have been stockouts due to problems in manufacturing, global supplies, supply chains. The same thing has happened at the lower levels because of shifting priorities and failures to supply contraceptives. Couples have switched to less effective traditional methods, increasing chances of unintended pregnancies. And then all of a sudden, in some countries, there has been a surprise of a change in method mix. People who were relying on IUDs or who wanted to go for terminal methods or permanent methods are not able to do so because they are being asked not to come to health centers because of the fear of contracting the infection from health workers, other patients, or from surfaces in the hospitals. As a result, there has been a surge in demand for emergency contraception and abortion in many places. Next slide, please. The UNFPA Asia Pacific Regional Office prepared a model on the possible impact of the COVID-19 pandemic on general sexual and reproductive health issues. What we did was we purposely selected 14 countries from the region, and these countries are Afghanistan, Bangladesh, Bhutan, Cambodia, India, Indonesia, Laos, Myanmar, Nepal, Pakistan, Papua New Guinea, Philippines, Solomon Islands, and Timor-Leste. And as you can see, the study modeled a best case and worst case scenario of COVID-19's impact on family planning and maternal mortality. The model, we had a best case scenario where there could be a decrease of 20%, a worst case scenario where there could be a decrease of 50% in the coverage of access to contraception. That could lead to a large number of unintended pregnancies. In the year 2020 and 2021 alone, as per the model, there could be an increase between 11.4 to 20.7 million additional unintended pregnancies in the region compared to the baseline that was achieved in 2019. So we can see this has really affected, the pandemic has really affected the health system and sexual reproductive health in the region. The combined effects of COVID-19 pandemic on the availability of short-term modern contraception would mean that the unmet need for family planning could spike in 2020, increasing by 21% to 40% on an average compared to the projected value since 2019. In the worst case scenario, this would entail reaching a peak of 26% of women with unmet need for family planning. Next slide, please. As we saw earlier, the pandemic has had a clear impact on maternal health and on the health-seeking behavior among pregnant women. More women are now avoiding antenatal visits and opting for delivering at home because of the fear of contracting the infection from health workers or from hospital services. This is likely to result in increased maternal and neonatal mortality and morbidities such as obstetric fistula, which is common in some countries of the region. Quality and availability of essential sexual reproductive health services has been adversely affected, including basic and comprehensive emergency obstetric and newborn care and skilled attendance at birth. The maternal health workforce is not well protected, and adequate personal preventive measures such as PPEs are not available for everyone. Next slide, please. As you can see, this slide would show that there could be an increase in average maternal mortality rate across the 14 countries in the region that we had modeled. And because it is anticipated that the skill attendance at birth and the institutional deliveries could drop by 20 to 50%, the best and worst case scenarios. In 2020 alone, the maternal mortality rate in these 14 countries could have seen a 17 to 43% increase, respectively, for the best and worst case scenarios, reaching 214 per 100,000 live births per year to 260 per 100,000 live births per year, compared to the projected baseline of just 184 per 100,000 live births in 2019. Next slide, please. Now we come to what happens when countries are facing such a pandemic. Many countries, many governments have come up with innovative ideas how to address the issues, how to address the challenges. I'll take the example of Papua New Guinea, where in order to improve access to contraception in underserved and remote areas where the government presence was limited, the government decided, as per the advice from UNFPA, decided to loan contraceptives to a private NGO. And that private NGO, because it was based there, this is something, it was a unique experiment in Papua New Guinea, where a private NGO received contraceptives on loan from the government and distributed them in a very far-flung remote area. And it was a very successful experiment. And the government plans to partner with this institution in the future as well. Many countries introduced telephone helplines and hotlines with 24-hour services throughout the week, including in Bangladesh, India, Pakistan, Philippines, and also these provide data regarding the availability of services, the availability of facilities where contraceptives could be available, and also answer frequently asked questions. Mongolia had an ongoing telemedicine project for safe motherhood, which has now been expanded to include family planning. In Myanmar, the government decided to partner, the Ministry of Health decided to partner with other ministries like the Ministry of Internal Defense, Ministry of Forestry and Agriculture to transport contraceptives from the central level to the provinces. And then in India, we had an SMS-based logistic information system that could, where a health worker, even in a village, could send the data on the availability of stocks to the central level. This has been now expanded to the lowest level, and also the government of India came up with training e-modules for all levels of health workers during the pandemic. Then also, as I mentioned earlier, in Bangladesh, teachers and community mentors came together to help adolescent girls on sexual health issues by home-based phone lines, not mobiles, household phone lines, where in groups of threes, these teachers and mentors counseled girls about menstrual hygiene, about reproductive and sexual health. Next slide, please. Similarly, in Laos, the government decided to partner with UNFPA to undertake an analysis of the distribution and consumption patterns of contraceptives in the first three months or the first quarter of the year, so that we could focus the government's attention on how the use has gone down and how the government needs to increase its support, its focus on family planning. In Cambodia, the government, along with partners, developed social media messages that have been very popular and that have been used by adolescents and adults alike. Similarly, in Pakistan, the government decided to support national socio-economic impact assessment, and that was the reason why we came to know that many women were talking about hunger and talking about non-access to contraceptives. And finally, in Indonesia, the government undertook an assessment of COVID-19 impact on the sexual reproductive health services, including the socio-economic impact of COVID-19. Finally, Indonesia, the government of Indonesia partnered with many organizations, including UNFPA, to promote partnerships with faith-based organizations and religious organizations to make sure that COVID-19 does not disrupt a successful family planning program in the country. Next slide, please. Finally, just to conclude, I would like to add some conclusions or suggestions based on our observations. As we have seen, unmet need for family planning is likely to spike or go higher in the coming years. And in the worst case scenario, it could reach a peak of 36% of women with unmet need. The government or the policy planners need to ensure comprehensive sexual and reproductive health service provision as a part of essential services, including family planning. They need to provide adequate protection for service providers. They need to have a greater domestic investment in health system strengthening and improving availability and access. We talk about universal health coverage and universal health care. The idea of improving availability through helplines and counseling is always welcome. And similarly, the ideas of innovations of e-modules and telemedicines can be learned from these countries. Finally, no governments can reach everyone. We need partnerships. We need to expand partnerships, not just with traditional players and traditional partners, but also with individual private practitioners who are working, including private practitioners of traditional medicines who are working in remote areas. And these private service providers and even private drug shops and private pharmacies have been helpful in many countries. Partnerships with other ministries and departments and encouraging innovations need to be promoted and encouraged. Thank you very much.
Thank you very much to all our presenters. And now we're going to open it up for questions. So please take a moment and post your questions on the Q&A. And I will address them and ask our presenters to respond. So I'm going to start with a few questions that are already posted. And we'll start with Beth Kangwana, and I see two questions relate to contraceptive use in Kenya, and one relates to what was the contraceptive landscape and some of the changes in contraceptive use before the pandemic, and can you talk a little bit about the types of methods that are usually used in Kenya, the method mixed?
Thank you for those questions. So from our data, what we did see is there was likely to have been a decrease in contraceptive use after the mitigation, the COVID-19 mitigation measures were implemented. And we can allude to this because there was a decrease in people going to health facilities to access contraceptives, mainly because people were scared to access the health facilities because of COVID. We also saw in our qualitative studies that there was poor supplies of family planning methods. So, some of the respondents said that they'd go in and they couldn't find the contraceptive that they used to use, or there was no contraceptive at all. We also saw that the pandemic decreased access to financial resources. A lot of people lost their jobs. And what we saw was that, and you saw in some of the comments, that people would rather use the little money they have on food rather than on healthcare services. So I guess all of this is alluding to the fact that it's likely that contraceptive use was low due to access. In terms of what types of contraceptives were being used, we saw that adolescents were mainly likely to use injectables compared to pills. Pills were very low in use, but I don't think that trend is any different to what we saw before COVID happened. So that would be my input to those questions. I don't know if Karen, my colleague, might have something to add to that.
Thanks. No, just one interesting thing that also was in the data is that actually, in particular around adolescents, is that because of all the lockdown measures, they were less likely to to be spending time with their partners, and I think that might change some of their motivations for spending limited resources on family planning. Thanks.
Thanks, and I think there are lots of interest in your data. So one of the questions is, have you published this data, or do you have any plans to do so?
So the data itself is available on the Population Council website. We are in the process of publishing some of the data in journals. And we are still trying to sift through the qualitative findings. So the quantitative data is available at the Population Council website, and the qualitative data is soon coming out.
Thanks, and I'll ask just a last insider question about, I know you're about to collect a second round of data, and what kinds of questions and what are you hoping to find out with the second round of data collection?
I shall maybe hand that question over to Karen, who is the PI. Over to you, Karen.
Sure. So we actually just started data collection today on a second round of data collection. If Beth and I are looking a little bit tired, that's why. So now that we're almost a year into the pandemic, we'll be looking, I think in particular, looking at issues of pregnancy, school re-enrollment, and child marriage, so some of those longer term outcomes that I think might not have shown up immediately or within at least the first 3-4 months of the pandemic.
Thanks very much. And now I will turn to Jean Lambert. Jean Lambert, il y a quelques questions qui portent sur, bien sûr, les déclins des services de santé et la distribution communautaire de planning familial. Et donc, un des commentaires, c'est pourquoi est-ce que ce déclin a commencé dès février? Et question supplémentaire, est-ce qu'il y a d'autres facteurs qui peuvent aussi contribuer à ces déclins au moment des restrictions?
Oui, merci beaucoup pour cette question. Effectivement, nous avons nous-mêmes été surpris de constater que la plupart des données ont montré que les déclins ont commencé en février, bien avant le début de la COVID et puis le début du confinement. Mais cela nous a aussi attisé un peu notre curiosité pour voir comment s'est comporté la courbe durant les années antérieures. Mais bon, effectivement, nous n'avons pas eu le temps matériel de pouvoir faire des analyses comparatives et comparer avec les résultats, les courbes des années antérieures, puisque, comme je l'ai dit dans la présentation, l'un de nos objectifs, c'était de mettre rapidement à disposition des partenaires du portefeuille d'investissement de la Fondation Bill et Melinda Gates, de quels étaient les effets immédiats sur leurs activités et surtout comment chacun des partenaires était en train de réagir à cette situation nouvelle pour pouvoir maintenir un certain nombre d'activités sur terrain et aussi partager rapidement avec les autres partenaires ce que les uns et les autres faisaient, parce qu'on pouvait toujours tirer des leçons et adapter ses propres activités. Et donc, de manière régulière, après chaque 2 mois, on collectait de nouvelles données pour faire la mise à jour des mesures qui étaient mises en place, de comment les activités étaient menées, qu'est-ce qui était arrêté, qu'est-ce qui était adapté pour continuer à être fourni comme service. Et donc, effectivement, nous avons partagé cette question avec les gens qui nous ont posé la question ici pour savoir, les données ont commencé à baisser en février. Probablement, là je m'avance, je n'ai pas des éléments scientifiques tout de suite pour le prouver, mais bon, c'est la période qui suit les fêtes de fin de l'année. Probablement, il y a des soucis de d'approvisionnement en produits contraceptifs autour de la fin de l'année. Mais bon, ça peut s'expliquer aussi par rapport à ça. Et comme j'ai dit, peut-être aussi que la situation de la COVID est venue juste s'ajouter sur une situation qui était déjà naturellement en déclin, ce qui n'est pas impossible. Mais nous continuons nos analyses pour essayer de comprendre globalement comment expliquer ces courbes, surtout, comme je l'ai dit, en comparant avec les courbes des années antérieures.
Merci
Donc, voilà
beaucoup. Je vais passer la parole au docteur Sharma. Dr. Sharma, I know you need to join a new session. We have one comment for you. Thank you for excellent presentation. Could you say a bit more about how the high and low estimates projections of unmet need were determined in your model?
Thank you very much. A number of issues were taken in consideration when we conducted that study of the model. It was based on the baseline of how much was the unmet need, what was the contraceptive prevalence rate for modern contraceptives, the health systems status in the country. For example, Afghanistan would be different from what is in India. And then also we projected what would happen if a certain number of people could not reach those facilities or the facilities were not functional. There are a number of parameters that were taken into consideration, and from that we arrived on two scenarios. The best case scenario when the impact would be less, and the worst case scenario when the impact would affect the system, the health workers, the availability, and the access. So these were a number of parameters that was taken into consideration in the model. Thank you.
Thank you very much. And now I want to travel from sub-Saharan Africa to the US. And this is a question for you, Laura. Some PMA data in several sub-Saharan African countries found that women's desire to have a child has increased slightly, or actually didn't decline. So do you think the difference in the US results reflects differential impact of COVID in US versus some other types of settings? And based on historical responses to crisis, do you think fertility desires in the US will rebound?
Thank you for that question. And the PMA data certainly sounds interesting. I mean, I think we are going to see variability across settings, just as we've seen variability in responses. Even within the US, the difference between where you lived and how extensive the lockdown was, whether schools were closed, whether you continued to go to work or not, has been great. And that certainly is going to have an impact on people's feelings about fertility. If you've been a parent at home with 1 or 2 toddlers during this time period, I don't know how excited you are about the thought of planning another child right now. Whereas older women who haven't had a first birth, maybe they're not going to wait because time is ticking, and they're the people who were most likely to be able to work from home, continue to have the same salary. Their investments have been going well. So I think we are going to see a lot of heterogeneity in these impacts over time. How long will it last in the US? I think remains unclear. I mean, yes, we're going to have a return to normal, but our normal was a declining fertility rate. So separating out that trend from this impact over the long term, we may never really know, or we'll leave that to econometricians to try to parse out in fancy models.
Thank you. And I think we are just on the hour. So just a round of applause to all our presenters. There are many other questions in the chat box. So I hope we'll have a chance to read your publications and globally contribute to this very unsettling and ongoing epidemic, as well as economic crisis, and find innovative solutions to address them in the months to come. Thank you very much.
Thank you.
power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.
Because our bodies and the future we hold it. We want for you to see that everybody can win. Could it be education or contraception? Everyone will always be here to sing.
We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We on the ground in every area. We're the ones to make a world a better place. We want the best, we want the way. There is something for